system in the US. So one of the ways to summarise how we may be able to do that is to improve competition, to have a centralised reimbursement system, have more government efforts to reduce drug prices, and to have some physician and patient-led solutions. They've listed a whole host of reasons why it's high and what they might do, and I've just shown you one or two here. But another one is that in generic terms, for generic preparations, there's something like 500 drugs available in the US without a competitor. So you can't have competition to drive the price down unless you have a competitor, and if you have no competitor, the price stays high. I'll just run through these things here. So this is what an article was lamenting, that Congress should go back to what it was trying to do before and do it again and do it better to improve competition and therefore make medications more accessible. Drug regulatory authorities are also part of the problem, and I won't go into this in much detail, but there are instances when they have come in and established rules and regulations on the use of medications which were not shown by evidence-based studies in the original pivotal trials. So they too have contributed to some extent to the rigidity of the system. It's happened in Europe and it's happened in the US. So how might we identify and quantify this? Well, the World Health Organization earlier this year, and has this topic listed again for early next year, is looking at inequality of access as well. We've partnered with the World Health Organization in the Atlas preparations around the world, looking at what facilities and what resources are available. The problem, to some extent, is the accuracy of the data. But nevertheless, it shows the same thing, that there is a high level of inequality and inequity of access to medications and to resources. The EAN, the European Academy of Neurology, has surveyed its members on national neurological resources. The AAN, the American Academy, plans to develop a disparity file within the states, and the WFN is preparing a needs registry. This is a somewhat daunting slide showing North America and Europe, population just over 1 billion, whereas the rest of the world, which is where the WFN is focusing, 6.5 billion. So you can see there's a very big effort required here. How might we do this, develop this needs registry? Well, the WFN is fortunate to have 122 member societies, 6 regional organisations, including the AAN and EAN, but also the African Academy, the Asian and Oceanian Association, Pan-American Federation of Neurological Societies, and the Pan-Arab Union of Neurological Societies. And it's planned to have some pilot studies on this needs registry in these 3 areas in the not-too-distant future. We're also very fortunate that preparations had begun by my predecessors, Professor Haczynski, followed by Professor Shakir, and also Werner Hacker, to develop the forerunner of the Global Neurological Alliance. That is, the World Brain Alliance included all the other major neurological societies which weren't, major neurological societies, but not specifically neurologies, like the neurosurgeons, like the psychiatrists, like the Child Neurological Association, EBRO, here. And then this next one is was the Specialty Neurological Alliance, but these include all of these organisations here: the World Stroke Organisation, Alzheimer's International, International League Against Epilepsy, Headache Society, Parkinson's disease, movement disorders, multiple sclerosis, all here. So covers all the areas of neurological disease which we are directly involved with. And then within the WFN there are a number of smaller groups: Huntington's, imaging, migrant neurology, which we'll hear more about at this meeting, ALS and motor neurone disease, and so on. So this grouping provides a very, very powerful tool for advocacy to see if we can get change regionally, nationally and globally. So the approach is going to be based on partnerships. I don't think we can do anything at all to tackle the problem in 6.5 billion people without partnerships. So these are the areas which we need to work on in disease prevention and limiting disability. So if we have cures and ways of modifying risk, then we will reduce the burden. And I just put this slide here on the International Progressive MS Alliance, where they're looking at trying to develop treatments for progressive MS, which, as most of you will know, is an area of high unmet need, and ground is being made. Poliomyelitis, stroke, neurodegenerative diseases are also key areas. Universal access to a minimum of disease-modifying medications, the so-called Essentials Medicine List, is an initiative by the World Health Organization. So every country that is in difficulty has a means to leverage with their government what the World Health Organization considers to be a minimum list of medications. For instance, in multiple sclerosis, an area which I'm involved in, MS International is preparing an application to recommend to the World Health Organization that these 3 drugs, glutamate acetate, fingolimod and ocrelizumab, would be their essential medicines for multiple sclerosis and should be helped to be made available worldwide. Advocacy campaigns for those 2 initiatives which I've just mentioned, but also on brain health awareness. This is an area which I think, through no fault of our own, but we have not worked hard enough in this area to try and increase the awareness of the World Health Organization and national and regional governments, large NGOs, on the importance of brain health. So we need to use things like the Global Neurological Alliance just within the WFN's remit. We need to use the World Brain Day program to expand that in order to leverage these effects. And then finally, in education and resources, the World Federation of Neurology has neurological training centres which have been moved along considerably by Professor Shakir. There are 2 in Anglophone Sub-Saharan Africa and 2 in Francophone, and possibly a 3rd coming, and 1 in Mexico at the moment. And this is to increase the number of neurologists in order to try and improve access to neurological care. So I just want to close now by saying this is an ambitious project that we're engaged in, and I don't think it's going to be completed in any short time, but it is something which we have to develop, that we have to work with, and we have to encourage partnerships in order to tackle it. It's not going to go away unless everybody starts to act in concert, and I just wanted to highlight the upcoming World Congress of Neurology in this region next year in Dubai, where this will also be a topic. Thank you.
Thank you, Professor Carroll. It's our pleasure now to invite Professor Shakir Rad. Shakir Rad is the past president of the WFN. He was also General Secretary of the World Federation when we organized the World Congress of Neurology in Marrakech in 2011, and he is an honorary member of the Moroccan Society of Neurology and a friend of our society. Please, you are welcome.
Sabah al-khair. Thank you very much. I don't know what to say to my Moroccan colleagues. I'm delighted to be back home, basically. I've spent much more in this country than anywhere else in the world outside where I live at home. We've been coming here since the 70s, and we have huge relations and appreciation for our Moroccan colleagues. So thank you for asking me to come. Today I'm going to give a talk which I gave to psychiatrists, so please bear with me. I gave this talk to the World Congress of Psychiatry in Mexico City about 6 weeks ago. And they asked me to speak about something a neurologist would do in their kind of comorbidity. I want to start with, I promise this is the only slide I have where I have to read it, but you can read. But from the brain and from the brain only arises our pleasures, joys, laughter, and jests, as well as our sorrows, pains, griefs, and tears. Through it we think, we see, we hear, and distinguish the ugly from the beautiful, the bad from the good. Hippocrates. So the brain is the origin of all, whether it's neurology or psychiatry, of all defects that we deal with. So in answer to their title, which is Comorbidity in Psychiatry and Neurological Perspective, I think the answer is probably all our brain diseases. And I'll emphasize that in 4 ways as we go along. I have nothing to declare, and I will start with posing 4 questions. The first is, can there be a serious mental disorder with a normal brain? I'll hope to be able to give you some answers. I can't say that I will. Second question is, how precise are we in diagnosis, both in psychiatry and neurology? Is it comorbidity, or is it coexistence or causality, is the third question. The fourth question is, has the time come for precision medicine to prevail? And these are the 4 questions that I'm trying to address in the 20 minutes that I have. So let's start with molecular neuropathology. And this is a paper from Science published this year by Gandal and his group, which clearly states that the predisposition to neuropsychiatric disease involves a complex, polygenic, and pleiotropic genetic architecture. And they looked at 5 major psychiatric diseases: autism, schizophrenia, bipolar disorder, depression, and alcoholism. I'll not go through this paper, which you can find in Science, but I underline the last line, which demonstrates pathways of molecular convergence. So the same convergence in molecular biology may present in different ways in different major psychiatric illnesses. And the editorial that followed in Science talks about psychiatrists beginning to map the genetic architecture of mental disorders. And that's the theme of the whole issue of that science, neurology. So there is a quantitative genomic-wide characterization of cortical pathology across 5 major neuropsychiatric disorders, which I've mentioned. And they talk about there are similarities, but of the synaptic dysfunction and astroglial gene upregulation, which may represent astrocytosis activation or both. So this is the why. And the conclusion was that gene expression findings from study of hundreds of human brains could lead to diagnostic tests, that is in psychiatry, and subsequent therapy. Now, my 4 topics today are functional disorders first. Second one will be dementia. The third one will be severe depression. And the last one will be psychosis in Parkinson's disease. Now, let's talk about functional disorders. I'm grateful to Professor Stone from Edinburgh, who lent me these slides. And functional disorders are everyone's problem, not just neurologists. There are gastroenterological problems like irritable bowel syndrome, gynecological problems, chronic pelvic pain, they go to gynecologists, fibromyalgia, atypical or non-cardiac chest pain, post-viral fatigue syndrome, or they go to ENT for dysphonia, or they come to us with various functional disorders or dissociative disorders. Now, the examples here are those of those functional disorders. Other names used are conversion disorder, hysteria, non-organic, psychogenic, dissociative. You choose your name. And there are definitions and reasoning for each one of those. And as you can see here, the symptoms are variable in various parts of the nervous system. Now, this is the video which I need to work. And I was told I'll be given help. I think I press here.
Meet our third and final couple, 46-year-old.
I think you all know this. This is a gentleman who is having a functional dissociative or a non-epileptic attack. And probably in EEG telemetry units, this is probably 20% of those presented in an EEG telemetry unit have dissociative functional cause. I'll not dwell on this long, but this is just an example of this condition. Now, if we, these are the differences between a non-epileptic attack and a true epilepsy. I honestly will not go through this. You all neurologists, you all know this, but there are clear differences. Now, this is another movement disorder, and I think I press here. Oh, no, sorry. Here. This is functional tremor. You ask the patient to copy your rhythm
79,
with the good hand, and you'll see what happens to the tremor. When the rhythm is varied with the good hand, the tremor is reduced in the other hand, and you vary the rhythm and you'll see the difference. The tremor entrains, it stops, and then the patient just cannot copy the movement, as you can see now. You all have seen this before. Now, one of the most important issues is why. Well, there are predisposing factors, which are genetic, childhood adversity, issues, modeling, can be precipitated by injury, by emotional disorder, by life events. And then the functional disorder will start, and it gets perpetuated. I will not go through the reasoning. That requires a talk on its own. But it is a very, very neat study from Mark Hallett Group in NIH in the United States, where they had 7, I think, patients with functional tremor, like the man I showed you, and they asked them to simulate the tremor. So at one time, they were having their tremor, and then they were asked to make up tremor in the same patient. And they had functional MRI when they are simulating and when they are having the tremor de novo. And there's no question that there is hypoactivation of the right temporal parietal junction, possibly explaining the loss of sense of agency. I'll come to talk about that, of voluntary movements. And this paper was published 7-8 years ago in Neurologie by Mark Hallett and his group. So there is a functional MRI change in tremor, functional tremor. And all of you, or some of you, might have read the book of Oliver Sacks, the late Oliver Sacks, A Leg to Stand On, and he gives an example of functional paralysis after physical injury. 2 further conditions to consider in the issues. One is factitious disorders. Factitious meaning that the motivation or gain is internal, responding to psychological drives such as need for attention or to reduce loneliness. And the other one is malingering. Is malingering a disease? It is in ICD-11, the new ICD from the WHO, but as a condition related to medicine and not a disease. People who make up symptoms to gain money, basically. Keep these in mind as well. Now, my second presentation is on Alzheimer's disease and the biomarkers. There are many phenotypes of Alzheimer's disease. I'm talking from subject to subject, jumping. But phenotypes are, on post-mortem, there's one particular pathology can map to different phenotypes: the amnestic type, the visual posterior cortical type, the language, the leukopenic type, primary progressive aphasia, behavioral, executive function, frontal type, all movement disorders associated like in CBD. Fluid and amyloid PET cannot differentiate. Tau PET shows regional variations. Now, this is a recent paper published by Ronald Peterson in Neurologie, and it shows that the changes in A beta and tau, I hope I'm pressing the right, oh, no, the wrong button. No, I really messed it up. Here we go. There. And you can see here, I think that's the pointer, you can see that these changes in A beta and tau precede the MCI, minor cognitive decline, or where I am now, the subjective cognitive decline, the one before, which people of a certain age starts having round about here, but they precede that for years. You have these changes in your biomarkers. Now, probably the most elegant work is done in Amsterdam by Philip Shelton's group, and this is the ABIDE project, where they looked at individuals with oh, here I go again, with individuals with MCI and MRI imaging, as well as CSF study. They have a most wonderful setup of checking the tau and A beta, which are difficult to test in most people's hospitals and labs. And they looked at that, and they looked at these biomarkers, and these are the results. And this is, for instance, a typical female of 60 with a mini-mental scores of 24, and MRI showing moderate atrophy. What are the chances of dementia in 1 to 3 years? If you don't look at any markers, these are the quotations, 16% and 48%. But if you do the CSF A beta and the CSF tau, and if they are both normal, then the chances are much lower. At 1 year, it's negligible, it's nothing. At 3 years, it's only 15%. So these results have a meaning. Now, if you have the same patient with the same mini-mental score, with the same MRI scan, but the CSF shows a low A beta and a high tau, then the risk at 1 year of dementia is 23%, and the risk at 3 years is very, very high, is 84%. So these biomarkers make a difference. Does everybody agree? Not yet, but probably we are getting there. And if you look at individuals with subjective cognitive decline, a lot of us of a certain age, so I forget it's my age, that kind of stage before MCI, and you can see here that if you plot the A beta and the tau, that the less than 65, more than 65, the issue is that tau is a strong negative predictor for progression in younger patients, and A beta is a strong predictor for older patients. Now, my third answer to the 4 questions I posed is a condition called occipital bending. Occipital bending means that the occipital lobe is bent either from left to right, as you can see here. Oh, I'm struggling with this. Yeah, as you can see here, or from right to left, as you can see on the other side. And if you look at the bending, for instance, I don't want to press the wrong button. No, I pressed the wrong button here. That is normal. We see that a lot in individuals, but when there is enlargement of the CSF spaces and the bending is more to the degree that there is a fold, then that is significant. Why it is significant? If you look at patients with severe depression that do not respond to any psychiatric treatment, including ECT in the past, including all psychiatric treatments, and do an MRI scan on all of these severe resistant depression, you will find that the majority of them, or substantial number of them, will have occipital bending. So there is a structural substrate to severe, untreatable depression. And these are the groups. This is work was done by Mailer and his colleagues in Melbourne in Australia. And you can see here that the groups are, what am I doing? The groups are similar. And you can see here that the only difference is is in the CSF. Down here, there's a significant difference in the CSF space being larger in individuals with major depressive disorder. And the CSF intracranial volume ratio, the one at the bottom, shows that it's significantly different, being again larger in individuals with major severe resistant depression. And this slide shows you the left to right, no bending on top, leftward bending in the second panel, rightward bending in the third panel, and then the interhemispheric fissure crossing. What we are interested in is in the third panel. And right occipital bending is 3 times more in those with severe resistant depression compared to controls, more so in the female than the male. And if you look at the slides, there is the star shows you the significant occipital bending more in females, and it is left to right. Now, why is this the case? Well, the reason is that in the area that is bent, there is lack of or insufficient neural pruning. It means that the conduction time is longer, and it means that there are changes in the GABAergic system and abnormalities in cortical inhibition, perhaps leading to major depression. So here is a real severe psychiatric condition with a structural brain change. Now the question is, no wonder you cannot treat these people with antidepressants or with other treatments, because we're not dealing with the problem. The problem is structural. Now my fourth and last comment is on Parkinson's disease psychosis. Now, we all know that we think it's due to direct brain degeneration, medications, Parkinson's, other illnesses, non-PD medications, comorbid psychiatric disease, or would like to add one more. And this is called blind sight. I'm sure most neurologists know about blind sight, and there's nothing to do with all these eyes. I photographed this in Sao Paulo in the Museum of Modern Art. It's by a Polish artist. It just shows eyes. But what is blind sight? We all have it, but we don't know much about it. Blind sight is the ability to make accurate use of visual information in the absence of conscious visual perception. And it is called reptilian sight. It is what snakes have, what reptiles have, it's a phylogenetically old system where that's why you can't catch a snake. The snake is 10 times quicker than you because it sees you in its blind sight. The blind sight is much more developed in reptiles than as we grew phylogenetically more advanced humans. And it was described by Weissenkratz in 1986, conferred by Barber in 2004. It is achromatic S-cone independent vision. I'll show you what that means in a minute. The superior colliculus is insensitive to S-cones, blue and yellow color. But if you have somebody with a dense hemianopia from stroke and you shine a red light from the hemianopic side, the pupil still reacts. It does react because it goes in a different pathway, like you can see here. So we have 3 pathways of vision. I hope I'll press the right button. I'm not sure. Yeah, here. The original pathway is the pathway that goes to V1, which is called the conscious geniculostriate pathway. And then we have 2 subconscious pathways, much shorter, much quicker pathways that do not reach the V1 area, the occipital lobe. And if you can see it represented here, the visual pathway here is the normal one. And then there is what we call the emotional pathway. Why did the authors call it emotional? I'll come to that in a minute. But it includes the anterior cingulate cortex, the amygdala, locus ceruleus, nucleus accumbens, orbitofacial cortex, periaqueductal gray matter, and substantia innominata. So there is a lot of emotion associated with this. And the emotion will come in a minute, and their importance in Parkinson's disease I will try to explain in the next slide. So if you look at people with blind sight, like us. We all have sight and blind sight. But the proposal is that people with Parkinson's disease still have conscious sight, but they lose blind sight, like they lose their sense of smell early on. And I'll give you an example of that here. And if you can look here, people with blind sight, they correctly guess without conscious vision of moving objects in the peripheral field. So we can guess that. But people with Parkinson's disease, they have misrepresentation of peripheral stimulus, erroneous guess of moving objects in the peripheral field of vision. And that's why maybe they have a sensation of passage and a sensation of presence. A lot of you who see Parkinson's tell you, yes, I can see somebody in the room, but I know he's not there or it's not there. I can see little children. I can see animals in the corner of the room. If the curtain moves, I think it is, and so on and so forth. Also, their reflexive saccades and pursuit is defective. Here, in the normal, with normal blind sight, it's hypometric, fragmented gaze, no correct updating of saccadic sight, slowness of saccades, and prolonged fixation time. Thirdly, I think is very important, is the emotionality. Correct expressive and autonomic reaction with negative facial emotions. Why do we have to have facial emotions? The idea is people with Parkinson's disease who have lost their blind sight or defective blind sight, they have deficient or delayed emotional face recognition, especially for rage and anger, not for happiness. So they look at somebody, and if he's angry or they think he's not happy with them, they will not recognize that as quickly as people with blind sight can. That recognition is called secondary hypomimia, an impaired theory of the mind. I'll come to talk about that in a minute. All these are through the secondary pathways of vision, which do not go through the visual cortex. So they have sense of presence or passage hallucinations, visual triggered hallucinations. Saccades are hypometric. One of my patients, as a last example, I only saw him about a year ago. He's a very good tennis player. He said early in Parkinson's disease, I cannot yet judge when the ball comes. I miss it. I wasn't like that before. And his Parkinson's is very mild. So that when a moving object comes very quickly, they can't judge it quickly. And we all thought in the past, oh, it's part of bradykinesia. I'm sure people in movement disorders will have other theories, but this is, I think, as good as any. It affects driving. It affects emotional reactivity, and is different from alexithymia. When I discussed this some time ago with Wolfgang Griswold, he put me in, pointed this out for me, alexithymia, which is a totally different thing. That also needs a whole lecture if you want to talk about alexithymia. So a theory of the mind is the ability to reason about others' mental state to predict their behavior is deficient. So a lot of families with Parkinson's tell you he's not reacting to our emotions. Somebody died and it just, when I walked in the room, it didn't register with him. Well, he cannot recognize the sorrow, the rage, the negative emotions. Now, why we need negative emotions? Well, we need them because when we see a negative emotion, we have to run away from it as animals, and that cannot happen. The amygdala gray matter volume is important. I'll not go through this. But the burden of Lewy body disease in the amygdala is variable, and hence these symptoms are variable. The silent amygdala causes odor misidentification, which we all know about, sense of smell, autonomic disturbance, and visual hallucinations. So my final slide, the one before last, is President Obama, who in 2015 said precision medicine. This was the New England Journal article which followed that. And to quote President Obama in the State of the Union speech, he said, "Tonight, I'm launching a new precision medicine initiative to bring us closer to curing diseases like cancer and diabetes, and to give all of us access to the personalized information we need to keep ourselves and our families healthier." So, we have to say, is it brain disorders, mental disorders? And psychiatry needs more precision. We have to say words such as organic versus non-organic, structural versus mental, functional versus dissociative, acquired versus genetic, brain versus mind, all these terms require immediate reconsideration from people working in neuroscience. I'm sorry to have gone slightly over, but I just want to thank you for inviting me to give you this talk on the close connection between neurology and psychiatry. Thank you very much.
Thank you very much, Professor Shakir, for this excellent presentation that give relationship between the psychiatry and neurology. And psychiatry is not a functional disorder, but there is biomedical and imaging abnormalities that you demonstrate that. Now it's a great pleasure for me to introduce Professor Stephen Lewis. Stephen Lewis is the chairman of the Education Committee of the World Federation of Neurology. He is also editor-in-chief of the Continuum of Neurology, the long life learning in neurology. That's the journal. It is our resource for educating our residents, but also for continual medical education for graduated neurologists. He is also editor of World Neurology. Welcome, Professor Steve Lewis.
Thank you so much. And thank you for this gracious invitation to speak at this wonderful conference in this remarkable city. And thank you so much for all the hospitality you've shown me during my visit here today. It's my pleasure to speak about something where most of us in this room are very involved in, that is Continuum, the Continuum Lifelong Learning and Neurology Program, and specifically the AAN-WFN Continuum Program. This is my disclosure that as editor-in-chief, I do receive some compensation as editor-in-chief of Continuum. My objective is to discuss the AAN CME publication Continuum and the history of and current and future role of the AAN-WFN Continuum Education Program. Continuum was created in 1993 by Dr. Theodore Munsat, Ted Munsat, who was the founding program director of Continuum, and Elliot Mancall from Philadelphia was the first editor-in-chief. Continuum was envisioned as a series of courses with a course faculty with 6 courses per year, and those courses really existed in the form of journal issues. The course issue topics were divided into chapters written by faculty with CME and self-assessment as the main driver. In 2003, Aaron Miller became the editor-in-chief, and he instituted a 3-year cycle with 12 core topics and 6 non-core topics. The core topics would be repeated every 3 years. It evolved into a peer-reviewed journal, which was indexed by PubMed. A website was developed by the American Academy of Neurology, and individual articles were authored by content experts. As I mentioned, it was indexed in PubMed beginning in 2012. In 2013, I had the privilege of becoming editor-in-chief, and part of my goal was to increase the number of core topics from 12 in a 3-year cycle to 15 in a 3-year cycle. So we currently have 15 core topics that repeat every 3 years and 3 non-core topics. I'll give you examples of that in a moment. We developed larger issues, more inclusive, so that if you read every Continuum issue in a 3-year cycle, you really have the majority of neurology content as mastered as you can based upon reading a journal article. Here's the current Continuum core topics. We have behavioral neurology and psychiatry, stroke, epilepsy, dementia, and going on to sleep and spinal cord disorders. These are the 15 core topics that are all repeated every 3 years. Now, each issue is a brand new issue. So if you don't have the previous issues, that's fine. So in every new issue, in every new 3-year cycle, a brand new, hopefully improved version of that topic is created. These are examples of non-core topics. These are not repeated every 3 years, but these were the last 5 non-core topics in the last 5 years of the Continuum cycle. We had a neuro-ophthalmology issue, neuroimaging issue, a selected topics in outpatient and neurology issue. That was an issue we created to try to include some topics that just didn't fit into a typical core topic. So, for example, a selected disorder was Bell's palsy or trigeminal neuralgia or autonomic disorders. They just didn't fit into the typical core topic. We had a pregnancy neurology issue and a sports neurology issue. Many of you may know the Continuum for many years, really since its inception. It started blue but quickly became a gold-colored journal, but a little bit bland to my taste. And at the beginning this year, we made Continuum a little brighter. We did a complete redesign, both of the cover with the British artist Peter Grundy creating covers that sort of matched the topic, and the interiors are a bit more vibrant as well. This is the last 6 issues of this year from Child Neurology, Headache, Infectious Disease. I understand the Moroccan Society will be doing the infectious disease issue next in your Continuum course, Neurocritical Care, Spinal Cord Disorders, and Behavioral Neurology. Well, that's Continuum. It's an overview of Continuum. This is now a slide describing the origin of the AAN-WFN Continuum program. This was also a vision of Dr. Munset, and it was approved by the AAN board around 2000 as a collaboration between the AAN and the WFN to provide Continuum content for Continuum user groups globally in lower to lower middle income countries and some middle income countries as defined by the World Bank. And on the WFN side, this is a component of the WFN Neurology CME program, utilizing local coordinators as points of contact, user groups meeting in person, where participants learn the Continuum content, discuss the Continuum content, and fill out evaluations. And every 6 months, a report would come to the AAN from the WFN through our coordinator at the WFN, Helen Gallagher. So what's the current goal? The current goal of the AAN-WFN Continuum program is to positively impact patient care, to collaborate in providing access to Continuum as an enduring reference, as well as a source of education to neurology professionals in lower middle-income countries, some middle-income countries as well around the world. This is a collaborative effort with the AAN as the source of development and publication, also with its publisher, Wolters Kluwer, publication of Continuum, and the WFN is an important partner in coordination, distribution, and evaluation of the program as a whole. So what's the current status? Well, currently it's still built around the idea of a country coordinator, society coordinator with user groups. 400 copies of each issue are shipped to the WFN 2 times a year. They're sent out in January and June, 3 issues with each shipment. Online accounts are set up with coordinator names and emails, and there are 45 participating neurologic societies. This is the distribution of the hard copies. Some countries get as many as 25 and some as few as 0, with the country really using online access to create its course. You can see Morocco has 0 hard copies, but is a very, very robust and highly successful program using the online access. So some countries rely a little more on online, and some countries rely more on hard copies as well as online. Every year we get evaluations from programs. Over most years it has continued to increase into the thousands. Last year was a bit lower, but the evaluations are much less important to us, frankly, than the fact that people are using it and learning neurology content from it. We received over 18,000 logins online from participating countries, showing how the online access has been beneficial. A couple of examples. Vietnam is a very successful program. This is the I think they do 4 times a year program in Ho Chi Minh City. With some flexibility in the program I'll talk about in a moment, this is an example of a very small program in Haiti where they have no good online access but utilize the print copies. And of course, here's the very, very successful, very robust program in Rabat with Professor El Alaoui and many people who are here in the audience. This has been really a role model program, truly a role model program for how a successful Continuum program can be. We look forward to many, many more years of successful Continuum programs and in cooperation with the Moroccan Society. So to summarize the current and future status, the AAN and the WFN are pleased to work together to share this rich resource to countries who can benefit, both for purposes of continuing medical education as well as an evolving and enduring source of current information to benefit patient care. So we want people to think about Continuum not just as CME, but as a source of material to benefit patient care while you're actually seeing the patient. We're all grateful to our local society partners and coordinators who work diligently and expertly to coordinate the program. But we do plan increasing flexibility in provision of the program, which we'll talk about in the next slide, And we've recently developed, between collaboration of the WFN and AAN, a survey which will be sent to current program coordinators in order to get further information to enhance the program. Here's a recent case study to show how we've used a little bit more flexibility lately with regard to print copies. So this past year, we found we had an excess of print copies of Continuum dating back to 2014. And those issues were actually about to be destroyed. And between collaboration of me and Dr. Griswold, and with assistance from Augustina Charway-Felly and very important help from Helen Gallagher, our coordinator at the WFN, Dr. Charway-Felly developed an alternative list of institutions in Africa with small but critically important training programs. We sent 2 copies of each issue in April of 2018, not 19, to neurology training programs in Burundi, which was the lowest on the list of Dr. Carroll's recent talk in terms of gross income, Cote d'Ivoire, Ghana, Kenya, Nigeria, and Senegal, and we'll be doing an assessment of how the issues benefited those programs. So in conclusion, I want to thank the Moroccan Neurologic Society and the Maghreb Federation of Neurology for this invitation, and thank you particularly for your commitment to Continuum and for the Moroccan Society for serving as a role model for a remarkably successful implementation of the Continuum program. Thank you.
Thank you very much, Professor Lewis. It's my pleasure now to introduce Professor Wolfgang Griswold, who is the General Secretary of the World Federation of Neurology, and his Moroccan adoption. Thank you very much.
Thank you.
Advocacy in neurology.
Yes, this one. Thank you. And where to address here? I need a pointer. Ici. Suivant, précédent pointer. Okay. Thank you very much. Good morning. Thank you for inviting me to Morocco and to the Maghreb in the wider sense, which I've been enjoying to see for many years, and it's a very interesting experience to be here and also see the wonderful development of neurology in your country. Thank you also for giving me the privilege to be able to talk about a soft topic as advocacy, which cannot be measured, there cannot be a graph, yet we need to do it, and yet we need to teach it. And this is my conflict of interest, I was privileged to, hopefully work, I was privileged to edit a book on advocacy in neurology, which is going to appear very soon. And 2 of my co-editors, Professor Rajakir and Professor Al-Alawi, are here in the audience. And the question, of course, is, what is advocacy? And this is a term that is used by many people all the time, and my talk will be focused on the social and medical aspects of it. It comes literally from something which is Latin, of course, advocare, to talk for someone or to speak for someone, and it's usually meant to have an altruistic background. The question is, who needs advocacy? And all of us who are in the room now may need it at any minute if we become sick. And who can be an advocate? Any one of us, despite being a doctor or being of a different health group, could be an advocate. And the role of advocacy is also different. It can be a navigator, it can be a mediator, it can be a person who helps, it can be a spokesperson, or it can be a person who is putting up a network for the patient. There are different steps in advocacy, and we decided to call it a micro, meso, and macro step. Micro step is a small advocacy act for one person. Macro would be for the world, that we have heard before. But this doesn't mean that one thing is more important than the other. But advocacy acts are very important per se. We also have heard that there are several types of advocacy, as grassroots advocacy, self-advocacy, patient advocacy, and also there is a very important term which is called counter-advocacy, which was used in by the Indian tobacco industry to stop some of the health policies. So it can go in both directions. And of course, we all know that advocacy is very much related to cultural aspects, and one advocacy concept that would be good in one part of the world may not be good for the other one. We were looking at something which is called epistemology, and epistemology inquires how we gain knowledge and investigate its conditions. It is also concerned with different types of knowledge, and we have used this also in looking at the word of advocacy. What is truth? What are beliefs? What are knowledge? What is knowledge? And it seems that we have to be aware of the tacit knowledge. Tacit knowledge means that people often say things without words, like in kinesics expressions or in paralanguage. And signing or drawing of pain, for instance, is a good example of how we approach the idea and the needs of the patient. There's also many concepts of advocacy that come from economics, from appreciative inquiry, from design thinking, and I'm just drawing here the example of the theory U, where you have a model, you dissect it into little pieces, let it come again, crystallize it, and embody it into a new structure. And this is very important to tackle problems, and a method that is recommended to look into this. Of course, how is seen advocacy by others? Well, first of all, advocacy is all about patients. But still, patients have particular needs, and I just picked out a few. One are the rare diseases. One is the need of patients to be involved in studies. And PCORI is such an example where people with the NIH develop studies. And of course, they need guidance. And I think I will show you a little bit of a confusing picture which shows the patient way in a diagnosis of the disease. He has an emotional way. He is exposed to many health people, specialists, doctors, nurses, and he has to make an opinion. And what we need to have, what we need to advocate is that to find a way that he is sure of himself and the level of confidence in our treatment grows. I also want to mention before I come to that nurses also have a very strong activity in advocacy, maybe more than we doctors. And I just want to quote one sentence from our book that says, advocacy is an activity to act in the best interest of patients, in accordance with the wishes of the patients. And that's very important. This is a picture from an NGO that takes care of children. It's called SOS, Children's Village. And they started off their activities in 1949. And they were growing, and they have now 130 villages around the world. But they found out that they were only focusing on providing good service, but they were neglecting advocacy. And they started, and this was a very painful route, to introduce advocacy into their mental things, and they were highly acknowledged for their work. And you can see here the CEO with the General Secretary of the UN, and they were also recognized as partnerships. And I'm very proud to say, and for your interest, there are also 4 of those villages here in Morocco that serve that purpose. So the next question, of course, is how can we teach advocacy? Can we teach that? And of course we can. And I think as we all advocates, physicians advocates, we have to think of how to teach it. And I want to praise the American Academy of Neurology, who entertains an advocacy workshop every year, which I'm going to tell you a little bit about it, who select applicants very carefully, and you learn to make a project, to mentor, to be mentored, and also to talk to press and get ideas how to communicate. This is at this American Academy workshop where let's say, an advocate is trained to talk to the press, and one of the most important things you learn here, bring it to a short soundbite, very short and brisk. And of course, they also introduced the world, the real life, and this was during one of their lunches. There's no free time, this is a working lunch, And you can see here a real senator who came and asked doctors questions, how a politician would talk to a doctor needing to know something. And finally, this comes back to somebody who is called Palatucci and was an American neurologist who had this idea to produce these workshops, which are highly recommendable, and they're called Palatucci workshops. And also the World Federation has a teaching course during the World Congresses featuring this topic. What are other fields of neurology doing? And in our book, we asked quite a number of different societies, what are they doing about advocacy? And very impressive were the activities of epilepsy, ILEA, who have their own patient organization. Also, I have to say, brain tumors have the IBDA, which is an independent patient organizations. But the interesting pattern here is that everybody does something else, and we need to unify our efforts in advocacy. I'm almost finished, and I think closing and ending is a very important part. As you know, any project is started with enthusiasm. It's a grand opening, and during the course of the project, like an advocacy project, the enthusiasm goes down, people disappear. But it's very important that you debrief people after a project, and you end every project by a closing where you realize what has happened, what problems there were, and what new strategies you can learn, and also how to deal with failure, because in everything we do, we may also have failure. So this is one advocacy project of the World Federation of Neurology, and Professor Carroll has already talked about the World Brain Day. This is going to be next year in 2019, and we do hope that Morocco and the Moroccan society will participate and spread the news. The topic will be migraine and, of course, other headache types, and we will do this jointly with the IHS, and we look forward to this occasion, which would reach the public and the press and inform them about the importance of headache. This is the book on advocacy and neurology, which is going to appear soon. And to finish off, of course, World Federation, you saw that slide. I have to add something, and I just add that on Monday, October the 28th, we have an advocacy forum in Dubai. It's free to enter. You just have to sign up, and we will tackle the idea of advocacy and making projects. And with that, a soundbite. The soundbite is advocacy is an important in neurology. Thank you very much.
Thank you, Professor Gizold, for your excellent presentation. Now, it's our honor and pleasure to introduce Professor Didier Leys from Lille, France, past General Secretary of European Academy of Neurology. He has to speak about dilemma in neurology, intituled Stroke Mimics and Chameleons in the emergency room. Please.
Thank you very much, Mr. Chairman. I am sorry for my voice, but I think it's a consequence of the air conditioning during the flight and maybe a little bit later. Stroke mimics and chameleon. Why is this a subject of interest? Because usually stroke is very easy to diagnose. Most patients with a stroke have a focal neurological deficit with a sudden onset, and usually most of these patients have a stroke. There is a low risk of making a mistake if we consider that these patients have a stroke. It's necessary for stroke patients to be recognized quickly. We explained why yesterday, but the rapid recognition for the stroke is needed because of acute therapies are available, mechanical thrombectomy, thrombolysis, for instance, and also because even for those patients who will not need acute therapy, early secondary prevention is always needed, especially in ischemic stroke, aspirin, for instance, anticoagulant in cardioembolic stroke, carotid surgery, and so on. In the emergency room, when we see the patient for the first time there are two possibilities. The first one, we think it's a stroke. The second one, we think it's not a stroke. And we will compare this diagnosis, stroke or not a stroke, with the diagnosis at discharge of the patient after a few days in the stroke unit, after the follow-up of the patient, imaging, and so on. And again, there are two possibilities. The first one, it's a stroke, and sometimes it's finally not a stroke. So in most patients, we have true positives or true negatives, meaning that we confirm the diagnosis of the emergency room, it's a stroke or it's not a stroke. But in a few patients, you will consider in the emergency room that it is a stroke, and finally your final diagnosis will be something else. We will see what. This is what we call a stroke mimic. It looks like a stroke, but it's not a stroke. And more severe, probably for the patients, sometimes in the emergency room, you will think that it's not a stroke, but the final diagnosis will be a stroke. And in these patients, we call of stroke chameleons, because the clinical presentation suggests another disorder, which is not always a neurological disorder. So I will start with the stroke mimic, and for a few seconds, you will imagine that you are not neurologist, you are a journalist, and your boss in your journal asks you to follow American presidents. There are journals like this, we call them People Journal. So try to find American president and take photo and show what they do and so on. And you are in Marrakech and you see this guy. Of course, you will think that it could be Barack Obama. You all agree he looks much like Barack Obama, so you will take your camera and say, your boss, I will have some pictures and maybe an interview with Barack Obama, but finally it's not Barack Obama. He looks much more, but it's not Barack Obama. It's a US president mimic, we can call him like this. This is exactly what we have with a stroke. We have patients with a typical presentation of stroke at onset in the emergency room, and the final diagnosis will be something else. If you look at different situations, you can see that the rate of this misdiagnosis may vary. The lowest rate of misdiagnosis is in the stroke unit, but you can see here that approximately in 15% of patients in a stroke unit, you will have a final different diagnosis. And if you go to ambulance, for instance, with paramedics, it may be close to 50% of mistakes. But I don't like this term of mistake because I will try to show later that we need these mistakes. If we have no mistakes from this type, that means that we will miss some strokes. Is brain imaging of interest? Yes, of course. But a CT scan can just make a difference between a normal CT or sometimes an ischemic stroke, which is already visible, and an hemorrhage. But it does not distinguish all mimics. A CT scan in a patient with a migraine aura, for instance, will be normal. And a normal CT scan can be seen in an ischemic stroke, for instance. The sensitivity of a CT for ICH will also decline with time. There is a typical possible mistake for these patients who arrive late, who are diagnosed with a brain hemorrhage, for instance, a deep hemorrhage, and finally this is not an hemorrhage, this is an ischemic stroke with an early hemorrhagic transformation. And even with MRI, with DWI, of course, if we see the patient very early, there is no risk of big mistake. But if we see the patient, or if we do the MRI later, after a few days, for instance, the sensitivity and the specificity for acute ischemic stroke will decrease. So imaging will not solve all the situations, and there is still room for the clinical investigation. What could be these mimics? The first possibility is a seizure. This is not something which is easy to diagnose if you have not the description by the patient or by the family, or if the seizure is already the consequence of a stroke. Yesterday I presented a case where the ischemic stroke started by a seizure, probably by a seizure, for instance. Or sometimes the seizure can come in a patient who had a stroke a few months or years before. So it's not easy to diagnose. Diffusion imaging may be helpful. especially the coefficient, the diffusion coefficient may help to make the difference. We have to bear in mind that most of these paresis last less than 3 minutes. And we have also to bear in mind that if we make a mistake, it's not something which is serious in this case, because seizures are not anymore contraindications for TPA. So it's not because there is a seizure that the patient should not receive TPA, of course, if there is a good indication for TPA. Hypoglycemia. Hypoglycemia is another possible mimic. It can present with focal signs, usually in diabetic patients, but not only. And it's good clinical practice to have a measure of the blood glucose in all patients who have a stroke, and usually this is made before the admission of the patient by the emergency physician. And there is a possibility that a brain MRI shows some modifications in case of hypoglycemia. So if the diagnosis is not made, you can see diffusion abnormality, but usually the coefficient, the apparent coefficient of diffusion is not modified, is not decreased in this case. Of course, it's better to make the diagnosis of hypoglycemia before MRI. It's easier to have a blood test. Migraine. This is something which is quite frequent, especially in young ladies. There are some clinical modifications. In migraines, for instance, usually the clinical deficit will happen not suddenly, but within a few minutes. So it's not something which is abrupt as we have in a stroke, but the diagnosis may be difficult if it's the first episode, for instance, if the patient is already a little bit old, and sometimes it may start later in life, or if the deficit is quite severe. But usually you have visual deficits or sensory deficits, and the diagnosis is not too difficult. Functional disorders. We had this wonderful talk from Raj Shakir just before. What we should bear in mind for functional disorders is that this is not a diagnosis we will do because we don't find anything else, but it's important to make the diagnosis because we have positive features. We had good examples before with the talk of Raj Shakir, but inconsistency, for instance, a patient who cannot move the leg and who is able to walk. This is something which is in favor of a functional disorder. The other sign, incongruities. For instance, if you have a dense right hemiplegia without aphasia or not involving the face, this is something which is not usual. Or if you have sensory disturbances which are not with anatomical design pattern. Tumors, but tumors sometimes will be expressed by a seizure or something like this, sometimes by also an hemorrhage in the tumor. What is the problem with mimics? The problem is that we will delay the diagnosis of the underlying disorder, but usually it's not a big problem. If you make the diagnosis of migraine a few hours later, it's not a major problem for the patient, for instance. The main problem with mimics is that you will have inappropriate use of, available facilities. These patients should not go to a stroke unit. You use a bed of stroke unit for these patients, and sometimes inappropriate treatments, especially TPA. There is no risk for thrombectomy, because for thrombectomy you need to see the occlusion. But for thrombolysis, it's possible that you will treat these patients. And this is a result of a study we conducted in Europe in different centers. We collected more than 5,000 patients treated by TPA. 100 had stroke mimics. And you can see that they have a profile. They are younger, they are more frequently women, and less frequently with vascular risk factors. Importantly, when we give TPA to these patients, usually there is no big problem for these patients. For instance, no angioedema, which is quite logical. They have no lesion of the brain. Very low rate of bleedings, only one patient with an ECAS2 criteria for bleedings, for instance. So it's not a major issue to give TPA to these patients if the diagnosis is not made before. So we have to go fast for stroke. And it's probably better to take the risk to treat a few mimics than to take 15 minutes more in 99% of patients. So everything is important is to go fast, and we should not be too worried about mimic. The risk will decrease with MRI, of course, and we should not blame an emergency physician because we have a mimic. If an emergency physician never refers a patient with a mimic, that means that this emergency physician missed a lot of stroke. What about chameleons now? I will be more quickly with the chameleons. You are still journalists, you are still looking for American president, and you have this picture with a guy who is hidden here. Here it's me. I am shaking hands with somebody. Who can be this guy? Probably not an American president. It can be the president of the WFN, or the past president, or the general secretary, or the president of the EAN, or the past president of EAN. It's unlikely that it is an American president, but actually it is. So this is a chameleon. It does not look like an American president, but it is. This is what we have with a stroke. These are patients who come for neurological features who do not suggest a stroke, but the final diagnosis will be a stroke. And the problem here is more severe than the problem with mimics, because these patients are not considered for acute treatments, and these patients sometimes do not receive an appropriate secondary prevention because there is no diagnosis of stroke. What can it be? Vertigo. This is a nightmare in emergency rooms, but we should bear in mind that only 3% of patients admitted in emergency for vertigo have a stroke if they have additional symptoms. And if they have no additional symptoms, it's less than 1%, so it's not so frequent. It can be monoplegia. This monoplegia looks like a peripheral disease, but for other reasons, disturbances in the sensory disturbance was not clear and not compatible with something peripheral. So this patient had MRI, and it was a stroke. This was not considered as a stroke at the beginning. Delirium, you all had already these patients with bithalamic infarcts, and sometimes these patients come for a psychiatric disorder. We had also comments on the psychiatric disorders, but the final diagnosis is not a psychiatric disease. It's a stroke, bithalamic stroke. This is quite frequent that these patients are admitted in psychiatry. And we have other examples. Foreign accent syndrome, for instance. This has been mainly described in English, native English speakers. Alien hand syndrome. Cortical blindness with denial of deficit. These patients are blind, but they don't realize they are blind. And this may be misdiagnosed as a stroke. And sometimes coma. For instance, here, patients with a coma at the initial stage, and this coma was not toxic or due to something else. It was actually a bithalamic infarct also. This is frequent also, but usually lasts only a few minutes. There are other chameleons. I will not go into details. Limb shaking, hysterexis, quite frequent if you look at it. Disappearance of a previous tremor, which can be the symptom of a stroke. So this is strange, but this may happen. So what is my take-home message? My take-home message is that the problem with a stroke mimic is not that the diagnosis was wrong, this happens, but that we give inappropriate treatments to these patients, and we use not properly facilities available facilities, but there is usually no consequence for the patient. We should not worry too much for stroke mimics. The problem with chameleons is more severe because stroke is not identified and treatments are not given. This may be more serious for the patient. Thank you very much.
Thank you, Professor Didier, for this talk. And now it is my pleasure to introduce Professor Antonio Frederico. Antonio Frederico is member of the board of the European Academy of Neurology and the Committee of Guideline Production Group. He's also member of the World Federation of Neurology and the group of Neurology and Migrants. He has a great contribution in neurometabolic disorders, and his talk today is entitled Mineral Accumulation in the Brain. Federico, the floor is yours.
Thank you. Thank you for this presentation and for the invitation to come to Morocco to this very interesting meeting. I am, as usual, at home here, and I thank you very much. So I will try to summarize the problem of some new data on an old problem that is related to the accumulation of the metal into the brain. With CT scan, MRI, we open the brain and we have looked at a lot of conditions in which different metals are accumulated into the brain. So we can have primary or secondary calcium metabolic disturbances. We can have some calcium accumulation in several mitochondrial encephalo neuromyopathies, and we will have some new forms that has been recently described. Some are in very young child and are cocaine syndrome and Aicardi-Gouttières syndrome. I will be very fast on this because we are mainly adult neurologists, but these are very complicated disorder with a very fast evolution in which there is microcephaly, rachitism, a peculiar phase, and dermatitis with psychomotor development associated with pigmentary retinopathy, spastic tetraparesis, and seizures, and there is a very severe demyelination, and the molecular level, there is a change in DNA repair. The same in Aicardi-Gouttières, there is a very fast evolution with basal nuclei calcification and mutation in TREX1 gene with calcium accumulation in basal ganglia. But we have also other form in which there is an extensive brain calcification that is always associated with leukodystrophy, with formation of cysts that has been described in young babies, and this is linked to a diffuse cerebral small vessel disease, a microangiopathy that may be present also in adults, as in these cases, in which you see the extensive accumulation of the calcium into the white matter, into the basal ganglia and cerebellum, with, from a neuropathological point of view, alteration in small vessels with angioma-like pattern and vascular and parenchymal calcification. This condition is now possible to have a molecular genetic diagnosis because it has been found a new gene that is NORD118 gene that is related to a cerebral microangiopathy, leukoencephalopathy with calcification and cyst, and this is one case that was the first case in which this molecular diagnosis has been detected, and this is a case that we recently have seen. 19-year-old man with a clinical history of early onset seizures, slow progressive neurological impairment, mild mental retardation, diffuse calcification as CT scan and MRI, and a new mutation of SNORD118. This is a ribosomal protein that is important for ribosomal biogenesis and function, and has also related with blood-brain permeability alteration, and it seems also that is a modulator of prion disease progression. But we know that cerebral calcification are very typical in the so-called FAR disease. In FAR disease, that is basal ganglion calcification, we know that at least 3 genes has been found in patients with similar clinical findings. The 3 genes are related to different function of calcium absorption and metabolism inside the different type of cell. One is related to sodium-dependent phosphate transporter type 2, the other in a receptor of platelet-derived growth factor, and the third gene is a platelet-derived growth factor beta. This has been identified 3 years ago, and we collected many families with FAR disease from all over Italy, and we have found different form of molecular genetic data, but the clinical presentation is always similar, even asymptomatic, sometimes with only psychic changes, and it's true what has been said before, the link between psychiatry and neurology, with some depression, some psychotic feature, and when they do CT scan, they found this alteration of basal ganglia with accumulation of calcium, and also it could be accumulation in cerebellum and white matter. The neuropathology is always accumulation of granular material in the affected region of calcification and deposit of calcium in the wall of small and medium size. The onset is usually around adult age from 30 to 50. It could be also asymptomatic cases, and it is necessary to screen out some secondary brain calcification related to parathyroid infection, lupus, and mitochondrial disease, and we can screen the different genes, so we can investigate phosphate homeostasis with the investigation of transporters of sodium-dependent phosphate, or we can investigate the signaling of the receptors of the phosphate, and we now have the possibility to learn a lot about the incoming and the outcoming of the calcium from the different cells, studying in vitro the different mutation. But the problem is the clinical heterogeneity and also the molecular heterogeneity. You see here several cases in which there is present psychiatric symptom with depression, bipolar disorders, motor tics, and dissective syndrome with basal ganglia calcification, thalamic and dendritic nuclei calcification, with other with seizure, other asymptomatic, and all with the same missense mutation. In other cases, we can have alteration in the export of phosphate, and also the clinical situation is very similar. So we conclude that in this syndrome there is a very large clinical heterogeneity that is related to the impairment of blood-brain barrier integrity, and secondarily vascular and perivascular calcium deposition. Very recently, other mutation in the transport of phosphorus and calcium has been reported. The phosphorus T2 protein, that was a protein not known before, and this situation has been investigated by our group in fibroblast of patients, and we have seen that in patients with classical basal ganglion calcification to the main mutation, is present an alteration, a secondary alteration of transport incoming into the phosphorus transport in the cell, with alteration in membrane, in plasma membrane, and in the nuclear compartment. This phosphorus uptake show that phosphorus depletion is present in patient and not in control. But also other mutation as recently reported. This is the last mutation in another protein that is MIORG protein that encode for a protein that is related to the protein glycosylation, and that is present in similar case of basal ganglion calcification. And here is our patient with ataxia and Parkinsonism, another patient with only tremor, depression, and anxiety, both with calcification and this new mutation. But basal ganglion calcification may be present also in other conditions. This was a patient that was sent to me for calcification in basal nuclei, cerebellar nuclei, and slight leukoencephalopathy and hydrocephalus. He had problem to the teeth with abnormalities in dentation, abnormalities in the face, and what was very important, abnormalities in the finger. So the message is look to all the patient. This is not a far disease, could be oculodento-digital dysplasia, that is a condition, a different condition of multiple malformation of the brain associated with basal ganglion calcification, in which has been found another mutation. The mutation is connexin 43, and this open a new area of molecular genetic analysis, that is connexinopathies, that are present in X-linked Charcot-Marie tooth, in skin disease, Pelizaeus-Merzbacher, and spastic paraplegias. We can have basal ganglion in many mitochondrial disease, but I will also spend some minutes about other mineral accumulation into the brain. You know very well Wilson disease. I don't speak about this. We know the treatment, but I will speak of a new condition that we had the chance to follow in the past year, was two brothers with Parkinsonian syndrome not responding to DOPA therapy, in which it was also present hepatomegaly, and in which it was this type of deposits in basal ganglia that was manganese, and you know very well that manganese is one condition, one toxic condition of Parkinsonian syndrome related, but this was a familial manganism. So we go into the problem. We have shown an increased level of manganese in the blood, in the urine. We have found a new protein that is SLC3810 protein that was not known before, is a protein that is able to transport the manganese to and from the cells, so there is a deposition of manganese into the brain that we can eliminate by a chelation by EDTA, and there is a dramatic improvement, as you see here, UDPR that increased dramatically, manganese that was decreased with this chelation. Another condition of mineral accumulation is iron accumulation into the brain, and here in the Maghreb is very well studied by the Tunis group that collaborate with some Italian group to describe this form. And in the Arab country, there is also Kufor-Rakeb disease that is an autosomal recessive nigrostriatal pallidal pyramidal neurodegeneration with Parkinsonism features plus spasticity, upgaze paralysis, and some calcification of basal ganglia related to ATP13A2 gene. But here there is also manganese accumulation into the brain, and also alteration in apoptosis and abnormalities in lysosome. So here we have a link between lysosome, mineral transport, small vessel disease that now is well known. You know that lysosomes are very much involved with synuclein for Gaucher heterozygous in the manifestation of Parkinson's disease, and also here there is a link between lysosomal dysfunction, alpha-synuclein, and neurotoxicity. So the problem of basal ganglia is a very intriguing problem, and I think that to go into these aspects is very important. We need to investigate such dysfunction, because from this disease we can open other conditions that are much more common. So rare disease like this are a useful model for understanding more common situation. And who is interested, at the end there is a very active task force of rare disease that will try to stimulate the interest of all the European neurologists in such rare case of neurology that are not some sophisticated butterfly collection model, but they may be useful for understanding the normal situation of the brain and pathological model that offer nature. Thank you very much.
Thank you very much, Professor Federico. Thank you for the audience. We are on time. You are invited to the pause.
Oui, s'il vous
coffee
plaît.
drink.
S'il vous plaît, donc